Hey guys, in this video I'm going to talk about the GERD, that is gastroesophageal reflux disease, which is a complication of hiatus hernia. So what are the factors that are preventing the reflex, and if these factors are not working properly, then we can see the GERD. So the factors which are preventing the reflex is lower esophageal sphincter pressure, which is 10 to 25 mmHg, and lower pressure inside the stomach, and secondary peristalsis from the cricopharynx to push the contents lower down. So these three factors which are related to the pressure works inside lower esophageal sphincter pressure, which is a lot more higher than the pressure inside the stomach, and secondary peristalsis. So this will prevent the reflux from the inside, even if the outer anatomy, which is a true crux of diaphragm, this prevents reflux by Pinchcock effect and higher intra-abdominal pressure in intra-abdominal part of esophagus, which is generally 3 to 4 cm long, means more than 2 cm long. This works from the outside, and we have learned in the hiatus hernia that the stomach part, gastroesophageal junction, will push upward, so this higher pressure will won't work, and crura of the diaphragm won't have the Pinchcock effect. But these three factors work from inside and can still prevent the reflex. Now the J junction angle, normally it is acute, and if obtuse then the reflux will increase. So how will the patient will present? So first heartburn, then water brush, which is due to increased salivation, then laryngeal spillover, means when reflux goes beyond the epiglottis, it will go into the larynx and lung aspiration, and it can lead to pneumonitis. Also in larynx, vocal cord nodule can be seen, and if it goes into the mouth, dental caries, and if in ear, then CSOM. So these are all the complications of GERD. And what is the local complications? So locally it will affect the esophagus, and there will be esophagitis, and it can lead to the peptic ulcer, and this can lead to stricture formation, and if stricture formation, then dysphagia can happen, and also metaplasia will convert into the Barrett's esophagus, and patient can also present with the pain, that is heartburn. Now for investigation, the gold standard is 24-hour pH monitoring. So we will put the two probes 5 cm above the J junction and 5 cm below the J junction. So 5 cm above means in the esophagus, and below means in the stomach. If the pH is more than 4 for at least 5 minutes, then it is a diagnostic. It is not more than 4, it is less than 4 here. हाँ, बंद कर दो. Then D-Mister scoring system is used for the diagnosis of GERD, and if the score is more than 14.7, then diagnosis is confirmed, and accuracy of 24-hour pH monitoring is 96%. Now we can also do the manometry to see if inner the pressure system is working or not, means lower esophageal sphincter tone is maintained and the peristalsis is normal or not. So if lower esophageal sphincter there is transient relaxation, means it is abnormal, or peristalsis is abnormal. So we have three conditions. First, sphincter is weak but peristalsis is normal, then we can do the fundoplication. Second, sphincter is normal but peristalsis is weak, when we can't do fundoplication. If both are weak, then fundoplication will be done. Here will be Door and Belse, that is partial fundoplication. Okay. Now impedance manometry, which is a new investigation, but first investigation, like in the hiatus hernia, we do endoscopy and we can see what erosion, ulcers, stricture and metaplasia hasn't happened and not, but it is kind of less sensitive. Now barium swallow can tell about the deep ulcers, stricture and hiatus hernia. For the management of GERD, first we will try to manage it conservatively, that is medical management. In that we tell the patient to avoid all the hot beverages, spices, oily food and avoid smoking and alcohol. This can all will precipitate the esophagitis and reflux, and there will be more acid secretion, so all the complication will be worsened if patient will consume this kind of food regularly. So first we will try to avoid this kind of food, so avoid all the local complication as well as the extra esophageal complications. Then lifestyle modification is by increasing the activity. We will do the patient to take medicines like H2 blockers, PPIs and prokinetics and gels. So PPIs are the main line of treatment here. Then the surgery. So Nissan's fundoplication is the complete fundoplication, means we are doing the 360-degree wrap, and it is done from the abdominal root and it is a posterior flap. Okay, and the how is the flap? It is 3 to 4 centimeter long and floppy wrap. Now in the side effect is gas broad syndrome, means distended abdomen and dysphagia, but it is not seen anymore. Then rare migration can be there, and the rare complication is pneumothorax. Now in partial lab, mainly 180 to 270 degree anterior, we have two flaps, Balsi and door. Balsi is done by thoracotomy and door is done by abdominal root. And in posterior rep we have Truppet, and less than 180 degree we have Watson flap.